Well, thank you for inviting me to speak here. I'm going to tell you a little something about myself. I have a significant fear of public speaking, which is ironic that I'm here right now. When I was a little boy, I started taking piano lessons. I was about 6 years old. And every year when you take piano lessons as a child, they do a piano recital. And my first one, I must have been 6 or 7 years old, they couldn't get me to go up on stage. The piano was actually up on a stage like this. You were alone. It was very scary for a 6-year-old, or anybody for that matter. Still is to this day. So I cried, screamed, and my parents begged, pleaded, threatened, yelled, did everything they could to try to get me up there. Eventually what got me on stage was that my father agreed to sit on the piano bench with me while I played. And we did that, and everything went fine, and I was done. And went on to do multiple recitals thereafter, which I never liked, without him sitting next to me. I'm only telling you that because I still have that fear of being in front of people. There are probably about 40 or 50 people here today. That's about 39 to 49 more than I'm comfortable with. So if I stop in the middle and ask my wife to come up and sit next to me, you'll know exactly why. Okay, I'm going to talk today about hormones. First of all, my name is Terry Harris. I know they did the introduction, but I've been practicing here in South Florida for about 12 years, a little over 12 years now. And when I started medical school 20 years ago, which makes me feel old, hormones were not controversial at all. First of all, how many of you are currently on hormones of any sort? Okay, so a few of you. Were there any of you who started hormones before 2002, more than 12 years ago? Oh, more people started it then? Okay. But are no longer on it, I assume. Some people have stopped. Okay. So, if you started them long ago, what was the conversation like with your doctor? There wasn't any. It was very short. These are good for you. They're going to help. They're going to keep you healthy the rest of your life. They're going to let you live longer. They're going to help your memory. They're going to help your heart. It's going to get rid of those menopausal symptoms that were making everybody so miserable, and still do to this day. Anybody here start hormones more recently? Say in the last few years? One or two, fewer. The conversation was probably a lot different with your doctor. The conversation was, you're suffering tremendously. I'm going to give you these hormones, but they're really risky. They could give you breast cancer. They could give you a heart attack. They could cause a stroke. I'm only going to give you a really small dose, and we're only going to use it for as little amount of time as we can, preferably 2 years or less. And we're going to see how you do. You might have to suffer with some symptoms. That sound familiar? So that was the conversation now. So what happened in the last 12 years that caused that? Exactly. There was a study that came out called the Women's Health Initiative, the WHI, and that was in 2002. Basically, they started the study of 16,000 women to try to confirm the benefits of hormones that we all had assumed were there. The benefits for heart health, the benefits for memory, the benefits for pretty much everything, aging. But they had to stop the study early in 2002 because they were finding a tremendously increased risk of breast cancer in women on the hormones, on certain combinations of the hormones. So when they see a big risk like that in a study, they have to stop it, and they publish that data. Scared the heck out of all of us. It scared women who were on the hormones because here you thought you were taking something that was good for you, and suddenly it turned out it could possibly kill you. And it scared us doctors because when we graduate medical school, take an oath to do no harm. And it seemed that we were giving these hormones like they were candy for years and possibly hurting our patients. So the second thing that happened, which is probably more important to me than to anybody else in 2002, is I graduated from my residency training. Throughout my residency, hormones we gave them out to everybody. And then the first month I was out in practice, treating real patients on my own without any supervision, suddenly I had to tell patients that I couldn't give them hormones. And I was lost. There was no training in my background to tell me how to deal with that. So quite a challenge my first month out. A scared young doctor with no real backup. And actually, the medical community didn't know how to interpret the data either. Everybody at first said everybody stop the hormones, and they said it's okay to take these hormones, not those. It went on for years. It's still going on now. There's still controversy about hormones. So what were my new guidelines for hormone therapy? Well, I had to give them to as few women as possible. I'm going to try to move out of the way a little bit here so you guys can see the slide. Give as low a dose as possible. Only give them for severe symptoms, and stop them as soon as you can. So problem solved, right? I had my guidelines and everybody was happy. Problem wasn't solved. I still had patients coming to me who were miserable with their hot flashes, night sweats, mood swings, and everything else that goes along with menopause. To make matters worse, people were stopping their hormones on their own without talking to me first. They were stopping them cold turkey on the advice of a lot of times their doctor, their primary physician, most often, said stop them right now. And concerning to me, very often, because their friends told them to stop them, which is something we struggle with all the time. People give medical advice, probably shouldn't be, but that's okay. We dealt with it. So what were the options for us? Okay, there were few options that I could use. I could either start you back on your synthetic hormones. The popular brand name at the time was Prempro, which still exists. It's still given out. And Prempro was actually the one that was studied in its generic form during that study that found the increased risk of breast cancer. I could give you over-the-counter medications or preparations like soy or black cohosh. Some of you may have tried these. It helped some people, probably about 50%, but still a lot of people were suffering. I could give you antidepressants. Isn't that a joy to have a conversation with your doctor about antidepressants when you're not depressed? You're just sweating. Well, low doses of Zoloft and Prozac were the first medications to come on the market for this, and that's what we used part of the time. Or, best option of all, I could do nothing. And you could suffer. I wasn't having any hot flashes, so I was fine. All right, so with these choices, I was able to help some people feel better, but not all. And some people chose to suffer with the hot flashes. They went with the do nothing, and I couldn't blame them, considering the risks and the limited choices I had. Very unsatisfying for me and for my patients, as you might imagine. So a strange thing started to happen to me. This was 3 or 4 years ago now. I had patients coming to me with prescriptions from another doctor, another practitioner, for these mysterious products called bioidentical hormones. I had never heard the term bioidentical used in this fashion before. We weren't trained to know anything about them. I'm a stubborn guy. All right, ask my wife. She's here. She knows. First of all, I'm a guy, so we're all a little stubborn. You all know that. Secondly, I'm a doctor. And if you want to talk about a deadly combination of stubbornness and ego, I'm it. All right. This was outside the mainstream, obviously, since I hadn't been trained in it. So I actually argued with my patients. Anybody here ever get in an argument with their doctor? Okay, yeah, sometimes it happens. It's never a good outcome.
I did over hormones.
Over hormones, okay. Well, there you go. I got in several, not knockdown, drag-out fights, but arguments with my patients. And something that it took me a few years to learn as a practicing physician, the doctor always loses those arguments in one way or another. I'm sort of like the husband in a marriage. Can't win. All right, I can be right or I can be happy. We've all heard that before. So I might be right about the hormones, might be, but you weren't going to be happy with that if you came into me on these wonderful medications that were making you feel better. So we're either both going to be miserable, sort of like a marriage could be in that situation, or you're going to leave and find somebody else, again, leaving me in the dust. So it was better to try to find something we could both agree on. All right, so I did the research. I went to the sites that I had been taught to go to. I went to the American Medical Association. I went to the American Congress of OBGYN, which is the governing body for my practice. And I even went to places like WebMD, which doctors sometimes use to get basic information. Basically found no information about bioidentical hormones other than the statements that they were potentially dangerous. There's no proof they worked any better or were any less risky, potentially more risky. Don't use them. So that's what I told my patients. I said, listen, I did the research on this. You really shouldn't be using these. Patients are smarter than that, women in particular. That's why I chose my specialty. I'm dealing with the smarter sex. No problem, doctor, is what they'd tell me. You keep doing my pap smears. I'm going to go to this other guy to get my bioidentical hormones. So that got to me. Here I was, their gynecologist, and unable to provide them with something that they obviously wanted and needed and were doing well on. So it's the reason I became a doctor in the first place is I wanted to help people be healthier and feel better, not send them out to find somebody else to do that for them. I'm going to tell you a little secret about medical training that plays into all of this. We're all taught or told to be what I'm going to call modern physicians. We're taught that people are individuals. You should listen to them. Don't just tell patients what to do. You should help them decide what to do. I should be treating patients based on their individual needs and wants. But there's a big disconnect between what we're told and what we're taught how to do. I was told, for example, that nutrition was very important for health. Never had a nutrition course in medical school or in residency. So I had no idea why or how. Stress. Everybody here has heard that stress can make you sick. I never learned how or why or what to do about it. Only that, tell your patients to stop having stress. Very effective, as you might imagine. Another problem with conventional medical training is that we are taught to diagnose a disease and then to treat that disease. Once we've diagnosed you with a disease, it's very hard for us after training to separate the individual from the disease. So you're now the person with high blood pressure. You're no longer Erica. You're now the person with diabetes. You're now the person with menopause. So we're going to treat you with the options we have, and that's it. There's no thought about the individual. So they were telling us to treat patients as individuals, but not really teaching us how. And that's a problem. Any of you told you should just suffer the rest of your life with menopause? Okay. All right. That's not right. Nobody should have to suffer with the side effects of menopause. Because menopause can last anywhere from the symptoms from 6 months. Some people are very lucky and it goes away. But it can last the rest of your life. So, the thought that it's just going to go away just doesn't fly. So, given all this, I had to swallow my pride and I did some deeper research. All right. I wanted to find out more about nutrition, stress, exercise, and bioidentical hormones, but I couldn't find it from any of these sites. None of that information was there. So where did I have to go? I had to go to Oprah, Suzanne Summers, women's health magazines. I'm a guy. I can't be just sitting there watching Oprah or reading her magazine in front of other people. I'll lose my man card. Okay? Same with the women's health magazines. It's really lucky these things are in digital format because I could actually put them on my iPad or my phone and read them in secret. But through these sites, I found international organizations that were dedicated to bioidentical hormone therapy and holistic medicine, trying to treat the whole patient rather than just a disease process. So what did I learn about them? First of all, I learned that they are potentially better at providing relief than the conventional hormones that I've been taught to prescribe. I learned that they are safe when used appropriately, like any other medication. And I learned how to use them to treat patients as individuals, which was something I was told to do but not really taught how. So I was no longer simply diagnosing menopause and then prescribing a medication for it. I was actually able to find out why you're feeling the way you're feeling, test you to see what you actually need as far as hormones, which is something nobody ever does, and then form a treatment plan based on your individual needs. Not everybody is going to need the same medication. Anybody remember this guy? Marcus Welby. He was for those of you who don't know, but all of you do, he was a doctor on TV in the late 60s, early 70s. He had a reputation for treating patients as people and not diseases. That was, his big thing. And this is now what I was equipped to strive to be. I don't think I'll ever be that good, but it was a TV show. It was written for him, so to be fair. Okay, so let's talk a little bit about these hormones that I'm going to be talking about. First of all, what is a hormone? A hormone is simply a substance made in one area of the body that can be transported to another through bodily fluids, and usually through the bloodstream, in order to cause an action. There are lots of hormones out there. Thyroid hormones are some. Estrogen, progesterone, testosterone, those are the ones we're going to be talking about today. Those are called the sex steroid hormones. Vitamin D is actually a hormone. It's actually produced in your body and transported elsewhere. So anything that does that is considered a hormone. This is going to be on the test. Unfortunately, it's hard to see from far away. But at the top here is cholesterol. And at the bottom here, estrogen, testosterone, and progesterone's up here. All of these are made from cholesterol. Anybody here think cholesterol is all bad? No. Good. Too low is no good. If your cholesterol is below 140, you can't make these hormones. So people on Lipitor or other medications, be careful that they're not bringing you too low. It's not necessarily better for you. Okay, so I'm going to be talking about progesterone, testosterone, and estrogen today. And when I refer to hormones, that's what I'm going to be meaning, just for today's purposes. As a side note, look at the complexity of this system. There are at least 10 enzymes involved in just producing estrogen. Some of the enzymes work in both directions, and somehow our bodies manage to keep it all straight most of the time. This is also just one small part of a larger system, which is just one system of multiple in the human body. It is an absolute miracle this all stays together at all. So I was struck by that when I saw this slide. Okay, so what is a bioidentical hormone? Well, bioidentical, as it sounds, just means a substance that is identical to that produced by the human body. So when we're talking about bioidentical progesterone, we're talking about the same chemical structure as what your body naturally produces. Same with the estrogens, same with testosterone. Why is that important? Well, this is how hormones work in a very simple graphic form. It's a key and a lock situation. The hormones work through what are called receptors. This would be the receptor for the hormone down here. It recognizes hormones based on its shape and size. So if you have something that you're missing, if you're deficient in a hormone, it's always best to use something that receptor is going to recognize exactly. A lot of the hormones that are available for use, Prempro included, and I hesitate to use brand names because I don't want to downplay anybody, but those hormones aren't the same shape. There are variations purposely put into those hormones so that they will act similar to others, but they're not exactly the same, so the receptor doesn't recognize it as your body's. Some of the hormones, by the way, that are available through routine prescriptions through traditional pharmacies are actually bioidentical now. Over the last 10 years since that study came out, those have become much more popular. So there are some regular prescriptions that your doctor can give you that are bioidentical. So this is an example of the difference. All right, I'm not going to test you on this. On the left here is progesterone. That is the bioidentical hormone progesterone. That's what it looks like in your body. This is medroxyprogesterone acetate. You might know it as Provera. It's the pro part of Prempro. This was created to mimic this. Most of it is identical. This part here is the same. But this end here is modified. So when that goes into a receptor, the receptor sort of recognizes most of it and will act sort of like that hormone, but there may be unintended side effects from that. And that's actually part of the current thinking on why the WHI study came out the way it did, that these hormones may increase the risk, because they're not bioidentical, of things like heart attacks, strokes, and breast cancer. Bioidentical hormones don't appear to have the same risks. Okay, so why do we need hormones in the first place? Does anybody know? Yell it out. Okay, well, menopause to help with the symptoms, of course. Hormones are important for fertility. They're important for sex drive. They're important for bone growth. Let me ask the question in a different way. Where are these receptors for hormones located in the body? Everywhere. Estrogen receptors are in the brain, in the heart, in the lungs, in the skin, in the eyes, everywhere. Same with progesterone and testosterone receptors too. Is anybody here afraid of estrogen? Okay, I'm not surprised. It has gotten a bad rap because of the study that came out. But estrogen alone has over 400 distinct functions in the human body. These are just some of them. and they're all necessary for life. So progesterone receptors are everywhere as well. These are not to be feared. All right? They are part of our lives. Another question that I'm going to give you. Are everybody's hormones the same? Okay, good answer. The levels of hormones in everybody are different. We might assume that. And the receptors will have a different sensitivity to the hormones in different people. Receptors come from your genes. You make proteins that are receptors from your genes, and everybody's genes are different. So one person's estrogen receptor is going to react to that estrogen differently than another person's. Just like food sensitivities or medication allergies, everybody's a little bit different. So let me go back to my training a little bit. I was taught that if a woman is suffering from menopause, the reason is that she doesn't have enough estrogen. So we treat with estrogen. There was no need to test the levels of hormones at all because it wasn't going to change my treatment. I was also taught, and this may sound familiar to some of you, that if you don't have a uterus, if you've had a hysterectomy, you don't need progesterone at all. The only purpose for progesterone was to protect the uterus against estrogen. Were any of you told that at some point? Okay, we're on estrogen alone? All right. That doesn't really make any sense. We know that the levels are different in each individual. We know that the receptors are different for each individual. We also know that those hormone receptors are present throughout the body. So obviously progesterone has more to do than just protect that uterus. Okay, so until as recently as 3 years ago, I was throwing darts blindfolded. I treated menopause with one standard treatment, maybe throwing in some antidepressants in there, because I didn't know what else to do. And by the way, I don't know if this gives the right impression, but I'm comparing myself to this man or this boy, not the donkeys behind, okay? Even though my wife might disagree sometimes. That was my point. Okay, so what are these estrogens that we're talking about? We'll start with them. Does anybody here have a medical background of any sort? Nursing, doctor? Okay. So I'm going to give both terms, the medical term and the simple term, just so we make it easy for everybody. And I will not do this for very long. I don't want everybody to fall asleep here. So there are three main types of estrogen that we deal with when we're talking about bioidentical hormone therapy. The first one is called E1 or estrone. This is actually considered the bad estrogen. This is the one that is most associated with an increased risk for breast cancer. Unfortunately, it is also the predominant type in menopause because the other types actually go down. This one actually goes or stays up. So that's unfortunate. The second one is E2. You can see a pattern here, estradiol. This is the strongest estrogen. It's the one that's dominant pre-menopause, before you're menopausal. It's most involved in fertility and the menstrual cycle. It's also the one that decreases dramatically when you go through menopause. That's what's responsible for you having all your hot flashes, sweats, all that stuff. That just plummets. The third one is E3, also called estriol. That's the weakest estrogen. It's also considered the good estrogen, at least in our minds. It helps protect you against breast cancer. The reason is that all of these compete for the same receptors in the breast. If the weakest one can bind there, the others aren't going to be able to. So it's going to block out those much riskier estrogens. There are other estrogens in the body, mostly variations of these, probably 10 or 20 of them. But these are the big three that we deal with. This is, for comparison, this is conjugated equine estrogens, also known as the brand name Premarin, the Prem in Prempro. All right, this is made from horse urine. It has multiple types of estrogens. That's why it's called conjugated estrogens. Only one of them is bioidentical to humans. Unfortunately, that's E1, the bad one. The rest of them are all horse hormones. So what's going to happen? These are non-human hormones for the most part. They're going to interact with the receptors differently. And it likely explains some of the increased risks they saw in that study. They did not study bioidentical hormones in the WHI. I should make that clear. Those weren't even on the map at that point. Progesterone is the next hormone I'm going to talk about. This one gets shuffled aside for the very reason that we are all taught that the only reason for progesterone is to protect the uterus. Imagine my surprise when I found out that there were receptors everywhere for progesterone. And actually now progesterone is being used for other purposes, including decreasing brain swelling, after trauma. There are progesterone receptors in the breast, which have actually been shown to prohibit growth. So progesterone is actually protective against breast cancer, several other types as well. Conventional medicine is actually starting to see this a little bit. I've seen some information out there. If you Google it, you'll find that there are some practitioners suggesting bioidentical progesterone for women who've had breast cancer instead of tamoxifen, which has long been the standard. That's not standard of care yet. That is new stuff, but you're starting to see it peppered in the data. This is a big step for conventional medicine to actually recognize that progesterone has other uses. Talking about progesterone is a great segue into talking about balance. We've all heard about balance in our lives, right? Your professional life and your private life should be balanced. You should be eating a balanced diet. You want to remain balanced so you don't fall over. All sorts of ways that balance comes into the picture. It applies to hormones too. I once heard a lecturer refer to the hormonal symphony. Hormones can be considered different instruments, or if you want to make it more basic, different sections of the orchestra. If they're not all in balance with each other, then it's not going to sound very good. Same with hormones. Relative amounts are what are important. I'm going to give you an example that might resonate with some of you. Did anybody have anxiety symptoms when they went through menopause? Okay, all right. So the way I was trained, since menopause is low estrogen, give estrogen and those anxiety symptoms should go away. The problem is, a lot of times when we give estrogen only to a menopausal woman with anxiety, it gets worse. So it can't just be the estrogen that's causing all of the problems. It's a hormonal symphony. Estrogen is just one section of that orchestra. Progesterone, when you're talking about the brain, has a calming effect. Estrogen has a stimulatory effect. That's why estrogen helps with memory to some extent and alertness. Progesterone is calming. If you take progesterone at night, for instance, it'll help you sleep. It's a natural way to do that. So if you don't have enough progesterone to balance out the estrogen that's in your body, even if your estrogen is normal, you're going to feel like you have too much estrogen. And that's where the balance come in. It's something we call estrogen dominance, a term that is not in conventional medicine, but it describes exactly what's going on. The estrogen is very dominant here. So you're going to get anxiety if you don't have enough progesterone. So does anybody think that testosterone is a male hormone? You guys know all the answers. Good. Women need it too. Men make 10 times as much as women on a daily basis. But it has vital functions in women. Sex drive is the big one that everybody seems to know about. It's also extremely important for memory, concentration, your mood. It's a mood elevator. And bone strength. The hormone that is most important for building bone is testosterone. Estrogen just maintains bone wherever it is. So you need that testosterone too. Besides that, estrogen is made from testosterone. Here's testosterone, here's estrogen. There's only one pathway to get to estrogen. Maybe that was Adam's rib, the testosterone. So, you need the balance. If you have too much testosterone, which some women in menopause do, you'll get hair growth, you'll get acne, some people get physical aggression. Too little, brain fog, memory loss, depression, loss of sex drive, and osteoporosis. So testosterone's forgotten in women in a lot of places, in a lot of conventional medicine. So how should these hormones be used? Well, this highlights how important communication is. This is an operating room, and for those of you who don't know, when we're done doing surgery on a patient, in order to move that patient off of that table, they're still sleeping. So it takes 2 or 3 people to move that person off, and everybody needs to be coordinated. If we're not coordinated, and we actually do count to 3, that's the tradition. Then on 3, it's on 3, everybody moves, very important. That nobody be off, because then this happens. So communication is key. You have to tell your doctor what you're feeling now and what your goals and priorities are. Did everyone miss the feet here? Sorry, it fell off the side of the table. There are several uses for hormones. This is a quote from Alice in Wonderland, Lewis Carroll, that I liked. Would you tell me, please, which way I ought to go from here? That depends a good deal on where you want to get to. I don't much care where. Then it doesn't matter which way you go. So if you don't tell your doctor what you want, you're not going to be able to get to where you want to go. I believe that was The Cheshire Cat and Alice. Okay, got that right. Some of my high school reading remained. All right, so if you want relief of your symptoms, if that's a simple benefit you want, then our approach is going to be a little bit different than if you are wanting to get that balance or you want to treat osteoporosis. Now, there are going to be different ways to go about this. We're all told in medical school, as I said, to listen to the patient, but we're not taught how to do that. There's no time to teach us how to do that. Those 4 years are packed solid. One of the things I like about practicing medicine is listening to patients, working to understand what's going on. So the only way I can do that is for you to tell me what you feel and what you want. So it takes more than a 5-minute visit to do that. The next thing we're going to talk about is why you're feeling that way. The human body is extremely complex. There are a lot of factors contributing to how we feel and how healthy we are. Hormones are only a small part of it. So we're going to have to talk about nutrition. Are you eating the right foods? Are you eating harmful foods? Do you have any food sensitivities that could be making your symptoms worse? Exercise, smoking, these parts of your lifestyle also affect how you feel. Smokers have much worse menopausal symptoms than non-smokers. So somebody with severe menopausal symptoms, if I can help them to quit smoking, sometimes we don't even need the hormones. Stress is incredibly important. This was one of those things that we were always told, and you've probably been told by your doctor as well, that don't stress about it, it's going to make you sick. Well, how? If we can find an inciting event, a stressor we can control, a way to deal with that stress, or even a food product that's causing physical stress on our bodies, sometimes hormones aren't even necessary. We get rid of that, and you don't even need the hormones. So you can maintain your fear of hormones if you want, and still feel better. So once we've talked about the symptoms, we're going to talk about testing. Now, testing is a sore spot for conventional medicine. We're trained not to test for hormones before starting hormone therapy, because it's not going to change anything. Makes absolutely no sense. I'll give you an example. Is anybody here on thyroid medication? Okay, yes, that's very, very common. I guarantee you that no doctor ever started you on thyroid hormones without testing your levels first. It just would never be done in conventional or alternative senses of medicine. So how does it make sense to replace these hormones, estrogen, progesterone, and testosterone, without first testing what your levels are? If you have anxiety, for instance, and your estrogen level is high for some reason, if I didn't test that, I wouldn't know, and I'd just give you estrogen and you'd be worse. And then you'd leave and go find somebody else. So that doesn't help me at all. It doesn't help you either. So there are a lot of different ways to test hormone levels. Blood is the most common. You can use saliva, you can use urine. We have to test other things as well, nutritional status, blood count, diabetes. All of these other things can affect how you feel. Hot flashes are not always menopause. Should never be assumed to be that. It's probably why some of you are on thyroid medication, because they found a thyroid problem while you were evaluating for menopause. So then we'd be talking about treatment. And treatment for menopause, because of everything that is involved, is rarely just a prescription for hormones and then we're done. All right? There may be a prescription for hormones, but there's also got to be a plan for nutrition, stress relief, exercise. We've got to treat the complete you. This doesn't work. Hormones will only get you part of the way there. Hormones might not even be necessary, as I said before. We can change your diet. We can change your exercise pattern. We can help you with stress relief. We can't always get rid of the stress in our lives, of course, but we can certainly learn how to deal with it better. And that's where the importance is. The treatment's going to be different for everybody because everybody's an individual. And the responses are going to be different for everybody. So the same hormones might make you feel differently than it would make you. So we're going to have to reevaluate it. This is not something that you get a prescription for and then follow up in a year at your next annual visit. Unfortunately, we do need to see you more often to make sure everything's going well. Once we have you at a stable level, then we can back off the number of visits. So in medicine, as in life in general, it is very easy to categorize our lives in order to simplify. It's very important in some things. When learning medicine, for example, if they didn't simplify things for me or I didn't simplify it for myself, there was no way I was going to cram all that information into my head. So I had to learn disease processes and treatments, not individual care. At first, you have to learn the simple part. But as we all learn when we treat our first live patient, simplicity is an illusion. All right? It's not really there. We don't always succeed in looking at the patient rather than the disease. And when it comes to healthcare, individuality and customization are extremely important. I think the medical profession is finally starting to see this. The days of paternalistic medicine, where the doctor just tells you what to do and you do it, gone well before I started to practice, and are even more so now because there's a lot more education out there too. Women are coming to me knowing about things that I hadn't heard about yet, and I have to do the research at that point. There's no way to stop it. The internet is amazing. So, the second thing I want to say is that the human body is just too complex to treat any one system in isolation. That's why you can't just give a hormone prescription and call it, a day. You have to take a holistic approach to everything. All systems have to be working together in order to achieve maximal health. And then my third point, hormones shouldn't be feared. They are a vital part of our lives and important to helping us be as healthy as we can be. When they're combined with appropriate lifestyle changes, dietary changes, and nutritional therapy, hormones can be very powerful in helping achieve total wellness. And remember, we're all individuals, so we should all make sure we're being treated that way. If you're feeling well on your hormone prescription, why would there ever be a reason to go off of the hormones? With any medication, you want to use the lowest dose possible. And sometimes that lowest dose possible is 0. So if we do the other things to help you feel better, the nutritional therapy, the stress management, and you need less and less of the hormones, it's possible that you could come off of them completely. That also depends on what your goal is. If your goal is for symptom relief, you're more likely to be able to come off the hormones because, for one, symptoms do tend to get better with age, and two, those dietary changes will help the symptoms very well. If you're looking to have a balance of hormone levels, your body is not going to start making those hormones again. Once you have decreased your production in the ovaries and the adrenal glands, then it's not going to necessarily come back. It could increase a little bit with the appropriate other changes. So there is a possibility of coming off of hormones, and you still want to be on the lowest dose you can, if at all possible. Evista is a hormone modulator. Evista is what is called a SERM, a selective estrogen receptor modulator. What it does is it picks certain estrogen receptors that it stimulates and certain ones it inhibits. Evista is used for osteoporosis. It's also found to decrease the risk of breast cancer. And the reason it can do both of those things is it stimulates the estrogen receptors in the bone, but inhibits the ones in the breast. So it actually reduces your risk of breast cancer by 70%. It is not a bioidentical hormone.
What was the main thrust of her book that was such a hot topic?
The main thrust was the bioidentical hormones themselves.
Anyone in particular or just?
All of them. She actually, she uses a lot of supplements, a lot of hormonal therapies in many different ways. I actually had the privilege of hearing a lecture by her doctor, and she gave him permission to tell us what she was on, and it was a list of 70 supplements. She takes like 50 pills in the morning and 20 at night. It's over the top, I will admit that. And I have never given anybody that many supplements, for sure.
Probably through plastic surgeons.
Well, maybe. I don't know. He wasn't commenting on her plastic work. But yes, but she does look very good. And part of what she's doing is maintaining that balance. She's using the hormones to achieve that optimal balance of hormones. So her hormone levels are going to be very similar to a 35-year-old. And that's what the goal was for her.
My daughter, who's 36, suffered for her whole life with depression before she started to menstruate. And she now is using an IUD with a very small amount of, what would that be?
That would be a synthetic progesterone.
Okay. Has made an enormous change in her life.
Right.
Could she use something, a bioidentical hormone to do that as well?
She could, although I would discourage her from changing a treatment that's working for her. Even though it's not bioidentical, it is a small amount, and if that's helping her, more power. She should use that. But yes, you can use bioidentical hormones. You're talking about premenstrual syndrome, which a lot of younger women suffer from throughout their lives. And I've seen tremendous benefit from just using a little bit of progesterone in the week or two before their cycle. Symptoms go away. And it's absolutely incredible. I've actually done that without testing, which is against what I just said here. But in low doses, it's probably safe to do that. And patients, they do absolutely fine. Yes? Sometimes they are. Right. Well, there are traditional prescriptions that are now, and a lot of the patches that are used for estrogen therapy are bioidentical. They're estradiol. Those have been out for years. They became extremely popular 10 years ago, or 12 years ago, because suddenly everybody was like, get off the Prempro, let's start this. Vivel is one of them. There are several out there. Progesterone actually has a conventional prescription too for natural progesterone. It was called Prometrium, now it's in generic form, it's progesterone. The problem with those preparations is there are sometimes limited dosing choices. So when we're using bioidentical hormones I do use those. I use those all the time because some people want to go through their insurance. First of all, insurance coverage usually comes with a copay for most people that I treat. And the bioidentical compounded creams, which are done at a specialized pharmacy where they'll put anything into it that I want, usually cost about the same or less than a prescription from a regular pharmacy. I have substituted compounding prescriptions for traditional prescriptions all the time with great results. There's one in particular that costs $300 a month for somebody, and I compounded it, it was $50. So that's a big deal, especially for Medicare where there a lot of times is not drug coverage. So, okay.
Most of us have daughters or daughter-in-laws. When would be a good time for them to start to check to see if their hormones are balanced before symptoms show themselves?
The earlier the better, although we usually don't like to start hormones until somebody's at least 17, 18 years old. But to be checked for hormone levels, that can be done at any time. Anytime. Blood test would be the first step. Absolutely. It depends on the situation. The younger you are when you start hormone therapy, the less risky it is. That includes in the WHI trial. The average age of women in the WHI, I believe, was 67, which is an age well beyond what we normally would start menopausal hormones. So that was one of the controversies about the study, is that does it really represent what we normally do? Because a lot of these women were 75, 80 years old when starting on these hormones, and that could be more risky. So to finish answering your question, by the way, sometimes the bioidentical hormones will be covered by insurance. If you go to the right compounding pharmacy, they'll often submit it, and I've seen many of these prescriptions covered by a prescription plan. I mean, if you don't have prescription coverage, obviously it's not going to, but if you do, it may, and it may save you some money. I'm gonna say that again? Estranoreth. It sounds like a combined estrogen progestin pill. It's a pill. That is synthetic estrogen, and norethindrone is likely, I'd have to look it up for the name because there's so many generic names out there now, but that is likely a synthetic progestin, sort of like the medroxyprogesterone acetate I put up there. So no, I don't prescribe that very often. I still, by the way, prescribe birth control pills, all of which are synthetic, because women need birth control. I mean, there are limited choices, and not everybody wants an IUD with no hormones, or is ready for permanent birth control, which has no hormones. So I do have to prescribe the birth control pills. I don't love doing it because it has long-lasting effects, but we do what we have to do.
Synthetic hormones, do they get stored in your body unnecessarily?
Yes, is the simple answer. The question was, do synthetic hormones get stored in your body and act in dangerous ways? Any hormone you take gets stored in your body to some extent. Is that your phone? Okay. It's okay. Let me see if I can catch my line of thought here. Yes, synthetic hormones do cause other effects because a lot of these synthetic hormones are broken down in your body to other harmful metabolites. Your body doesn't know how to get rid of them. So they can be stored. Hormones tend to be stored in fat. And all of us have some fat. So you have to live. So it does get stored there. And it can overload the liver as well. Oral estrogen taken by mouth has to go through the liver first before it can work anywhere. The liver can get taxed by that. Any medication taken by mouth goes through the liver. Absolutely. Estrogen has some special metabolites that cause harm. They can cause increased risk of things like gallbladder disease, blood clots, all these. So I don't use oral estrogen if I can avoid it.
There's one more question.
One more.
Most of us have gone through premenopausal, menopausal, and are now in postmenopausal stages, which is different than menopausal stages. The symptoms are different. It's hair loss, it's skin dryness, it's vaginal dryness, it could be memory loss. You tend to say, well, it's because I'm getting older or I'm at a stage when all of these things begin to happen strictly because of age, not because I'm a woman. Are there any hormones that can be taken at a later stage in life rather than at menopausal stage, which my kids are in now, not me?
Right. The question is, are there, as you go through the stages of menopause, first the average age of menopause is 52 in this country. Most people will go through a time period of a few years where they have the worst symptoms of hot flashes, sweats, mood swings, and then sometimes the symptoms change, and that's very individual. Everybody's different. I have women who are in their 80s who still have the hot flashes who come in, so it doesn't always change like that. But if your levels are tested for these hormones and they are low, which they will be, you can replace them at any age. There are women who have started on hormones in their 80s. Gently, bioidentical, yes. At that age, I would always start with bioidentical. In fact, now, if I'm talking about menopause or postmenopause, I'm almost universally using bioidentical hormones now, just because of everything I said here. The few people I still have on Prempro or Premarin were on it before and don't want to stop it. And again, I don't argue with my patients very much anymore. So if they've been on it, I talk to them about the risks and then I give them the prescription. What I will do is put together most of the prescriptions we use will have multiple check boxes for different hormones, and I'll check the ones that you need and the doses I want, and they'll put them all together into one cream. A lot of times that can be done. Sometimes it's better to separate them, and even though that may cost a little bit more at the pharmacy, it can be beneficial to be able to adjust each hormone individually without having to re-prescribe the whole thing, and then you're paying more money anyway, until we get the right dosing. I think we should have time for one more, or one more question, and I know your hand was up.
Estrogen cream.
How about estrogen cream? You mean for vaginal dryness? Okay. Yes. There are different types of estrogen creams available, and we're talking about conventional therapy right now. There's estrase, which is estradiol. That is a bioidentical hormone. Yes, that one is bioidentical. It is messy because it's a large amount of cream for the amount of hormone you're getting. A lot of times in that case, first of all, it costs like $70 a month for most people. It's expensive stuff, $70 to $100 a month. I can compound the same amount of estrogen that's in that estradiol into a cream, about half a milliliter of cream, a lot easier to use, and it'll cost $40. So there are ways to get around that. The other cream that's available is Premarin, which is the horse hormones. I don't use that one. I'm happy to stay afterwards if there are any other questions, but I think we're done. Thank you very much. Thank you for listening and watching. If you'd like more information, please call my office at 561-826-3800 or go to my website at www.harrisobgyn.com.